It pains me that I wasn't able to be here with you in Chile, but that aside, it's my pleasure to be able to share our information that we're learning about the BEST trial. So these are my disclosures. Now, the world population is aging, and there is an epidemic of diabetes and obesity. And with that, there is also a worldwide epidemic of peripheral arterial disease, which affects more than 200 million people worldwide. And in fact, over the past decade, its prevalence has increased by 25%. Now, chronic limb-threatening ischemia, or CLI, is the most severe form of peripheral arterial disease. It presents with ischemic rest pain and tissue loss, and occurs up to 11% of patients with PAD. The goals of CLI treatment is firstly medical therapy to optimize cardiovascular risk, limb-related soft tissue therapy, and revascularization to relieve pain, heal wounds, preserve a functional limb, and maintain the ambulatory status if that is at all possible. Untreated, CLI leads to leg amputation and death. There are two revascularization options for CLI, which most of the time affects the infrainguinal arteries. One is surgical bypass, and another one is endovascular therapy. Surgical bypass has a rich history. The first bypass was performed by Jean Conlin in Paris in 1948. The world changed in 1964 when Charles Dotter invented angioplasty, and since then there's been a plethora of new endovascular techniques and devices available for us to treat our patients with CLI and PAD in general. But what is the current status of CLI treatment? Well, I would say it's pretty chaotic. It's expensive, and there's a lot of variability. This is a recently published paper on the expense of and the cost of CLI in the United States. And the authors concluded that it costs Medicare more than $6.5 billion. And by the way, some people think it's closer to $20 billion per year to treat CLI. Adherence to best medical therapy is quite low in the United States. Certainly a lot of room for improvement. There's tremendous regional variation in the prevalence of CLI, upper right, amputation in CLI, lower right, and revascularization for CLI in the Medicare databases in the bottom left. A lot of variability. There's also variation in the use of surgical bypass or endovascular therapy to treat CLI across the world, to be honest with you. This slide is from the Vascular Quality Initiative, which is a big quality initiative that includes more than 600 centers across the world. And you can see the centers are on the x-axis. On the y-axis is percent of patients who have infrainguinal peripheral arterial disease and CLI who are being treated with bypass. So you can see on the left side of this curve that there are some centers who do very little bypass. And on the right side, there's some centers who do a lot of bypass and everything between, a lot of variability. And so it was our interest in this sort of chaotic landscape of treatment of CLI to figure out, to ask the question about which revascularization option in CLI has the best outcomes, which revascularization option is the most cost effective, which strategy has the best value. That was the question that we asked. And in fact, we got together a group of experts in one room and we asked them this question. And unfortunately, we did not get an answer. The reality is that the published data is out there, but it's really limited by the fact that much of it is retrospective, poorly controlled. The endpoints that are used, such as targeted vessel revascularization, are really suboptimal. There's a lot of bias. Claudication and CLI are often lumped together, and the follow-up leaves much to be desired. A recent comparative effectiveness meta-analysis of all endovascular and surgical revascularization for patients with CLI, when they were compared, concluded that there is not enough evidence to guide clinical decision-making. And if you look at this pyramid of evidence, you can see that at the top of the pyramid is the randomized controlled trial, which represents the most internally valid form of evidence. Now, randomized controlled trials are the gold standard for research. They eliminate confounding factors, they minimize treatment and selection bias, they reduce spurious causality, and really are considered to be the most reliable forms of scientific evidence, even though they are hard to run and they are expensive. I want to show you what the evidence gap looks like in CLI. So you can see on the left are coronary artery disease trials, completed landmark randomized trials. In the left, in red. In the middle, in green, are completed randomized controlled trials in cerebrovascular disease. And I'll assure you that this is not a complete list. The list is actually much longer. And then on the right, there's only one trial out there, the BASIL trial, that was completed at the turn of the century and was a valiant effort on the part of Professor Bradbury, who completed the trial and led it, but really left a lot of questions unanswered. So you can see how more than 100,000 patients studied for coronary artery disease, only 452 patients started for CLI. And this is why we had an idea to organize a randomized controlled trial to help guide treatment of patients with CLI. It helped us that President Obama in 2009 earmarked $1 billion for cost-effectiveness research. It also helped us that the Society for Vascular Surgery prioritized CLI with its top 3 unmet challenges. And so in June of 2010, we submitted an R01 application to the National Institutes of Health, and we're fortunate to have the grant be released and approved and in 2013. And so for the past 7 years, we've been running the best endovascular versus best surgical therapy in patients with critical ischemia trial, which is a prospective, randomized, multi-center, multi-specialty, pragmatic, open-label superiority trial that aimed to enroll 2,100 patients at 160 clinical sites and was funded to the level of $27 million. The goal of BEST was to assess treatment efficacy, functional outcomes, cost, really value in patients with CLI who are candidates for both bypass and endovascular therapy. This is the trial leadership, and as you can see in our clinical coordinating center, I'm a vascular surgeon at Boston Medical Center. My partner, Matt Menard, is a vascular surgeon at Brigham and Women's Hospital, and Kenny Rosenfield is an interventional cardiologist at the MGH. And the 3 of us are the PIs of the BEST trial. Now, the BEST trial ran as follows. The idea was when the patient comes to your office, that could be done either open or endo. Those are the patients that were consented for BEST. Those patients were placed into 1 or 2 cohorts. Cohort 1 are patients who had adequate single segment great saphenous vein, basically best possible conduit for bypass. That's cohort 1. Cohort 2 was a much smaller cohort that included those patients who did not have single segment saphenous vein. And so if those patients were randomized to bypass, they would need to be done using either alternative autogenous vein or prosthetic vein. Then these patients were stratified into 4 buckets based on their anatomy, whether or not they had tibial disease or not, and on their clinical presentation, whether they had ischemic rest pain alone or tissue loss. And then the patients were randomized to either endovascular therapy or surgical therapy. And we left the choice of endovascular and surgical therapy up to the investigator, and that's why it's a pragmatic trial. We've chosen very good physicians, experts in the field to participate in this trial, and we said to them, you do whatever you think is right for this patient. So if the patient randomized to bypass, it could be done in situ, or it could be done in reverse position. If the patient was randomized in endovascular, anything could be used that was available at the time in the United States. So stents, balloons, atherectomies, drug-eluting devices, and so forth. The primary endpoint was major adverse limb event-free survival, and this was an endpoint that made much more sense than amputation-free survival endpoint that was used by others in the past. We had some interesting secondary endpoints, reintervention, free survival, freedom from CLI, freedom from hemodynamic failure, and so forth. We, of course, collected quality of life instruments, the VascuQual, EuroQual, EQ5D, and we are planning a robust cost-effectiveness analysis. BEST was a collaborative trial that included everybody who treats CLI in the United States. It really includes vascular surgeons, interventional cardiologists, interventional radiologists, and vascular medicine specialists. We've worked very hard to encourage teams, what we call CLI teams, to get together at every site where specialty PIs would work together to maximize collaboration between specialties to make sure that the trial was successfully conducted. And so BEST is going to answer a lot of questions. The penultimate question that BEST will answer is, how does infrarenal bypass with optimal conduit, namely single segment great saphenous vein, fare against endovascular therapy? That is going to be the most important question that BEST answers. But there'll be many, many other questions that BEST is going to answer. In fact, BEST is positioned to provide a treasure trove of relevant data about CLI and its management. And we believe that BEST is going to define an evidence-based standard of care that currently does not exist in this space. So BEST includes almost 1,000 investigators. As you can see, 74% of those are vascular surgeons. We actually did an analysis. This was published by Rick Powell several years ago. It turns out that the investigators participating in BEST in terms of their specialty makeup is very similar to what's happening, at least in the United States, in the Medicare database. So it turns out that the majority of patients with CLI in the United States are being taken care of by vascular surgeons. BEST is a global trial. So we had 134 clinical sites that were active, 115 in the United States, 14 in Canada, and then 1 site in Finland, 1 in Italy, and 3 in New Zealand. 3/4 of our sites were multidisciplinary. And so in terms of enrollment, the first patient was enrolled in August of 2014, ironically at Boston Medical Center. And the enrollment ended in October of 2019. And so we've had 1,843 subjects randomized. And you can see here, these are enrollment curves. As you can see, they had to be renegotiated with NIH because this trial was extraordinarily difficult to enroll. This is sort of the timeline, first patient in. And I'll tell you that on the average, we enrolled a patient a day. The last patient enrolled October 2019. Now, we've had a number of curveballs that were thrown at us. Number one, there's bias. So, an investigator might say, of course, you can do this patient endo versus open, but I think the patient should be done endo. Or the same patient could be brought in front of another investigator and they would say, no, this patient should be done open. And so bias was a huge obstacle in enrollment into this trial. That's why it took so long. And of course, the CAT-SNES analysis and the paclitaxel data also threw a wrench into the process, because we did have patients in the trial who were treated with paclitaxel, and many people have stopped treatment with paclitaxel, but not all, over the course of this fiasco. And then, of course, COVID. We're lucky that when COVID hit, we stopped enrollment, because I think that the trial would have been in trouble if that wasn't the case. And so we were in follow mode, but it was very disruptive to us. Another unanticipated curveball was the fact that we ran out of money. The trial was hard to enroll. $27 million seems like a lot of money, but if this trial was run by industry, it'd be closer to $100 million. And so we actually went out and started fundraising. And we went all across North America and were able to secure funds from the majority of vascular societies. Now remember, these societies don't have a lot of money, and many of them gave up to 10% of their net assets to the trial because they believed in the trial. You can see Viva Physicians gave $500,000 and Society of Vascular Surgery gave $100,000. We also approached industry. Initially, obviously, we did not want industry involved, but we needed help. And so we approached industry, and they gave. And so all in all, we're able to raise $5.5 million, which is incredible. And with that, we're able to finish the trial. This is a funding timeline. You can see where we are with this arrow. And so right now, the sites are closing. It's a rolling closeout. It's going to continue until October. And so we know for a fact that every patient in is going to have at least 24 months of follow-up. When we we found out that money may not be available, we were worried that we'd have some patients who would have very short follow-up. But we know for a fact that even though we have patients who have 7 years of follow-up, 6 years of follow-up, that every patient in is going to have at least 24 months of follow-up. And we believe that in early spring, we're going to know the answer, and hopefully it's going to be presented sometime next summer. And so we are in the home stretch. This is the climb to Everest. I always show the slide, and I usually sort of think of myself on the right side here of this line, but we're actually closer to the top. And we hope that with BEST, and also with Basel II, which is also completing its follow-up in England, we hope that the evidence gap in CLI is going to be addressed. Thank you.